Okay, we're live.
Excellent.
Excellent. Hi, this is Dr. Jose Barrera in San Antonio, Texas. I'm here with my fellowship director of how many years, Sam?
Hard to believe. 12?
12 years. Dr. Sam Most, who is one of the editors of our new journal and has published extensively in rhinoplasty surgery. And I asked Sam to come on board and speak to us about preservation rhinoplasty. Preservation rhinoplasty is not a new technique, but it's something that is currently being performed by many surgeons in Europe and South America and some surgeons in the United States. It offers promise for the select patient, and Sam is leading the way with preservation rhinoplasty in the United States. And so I wanted him to speak on that, as well on septal extension grafts and tongue and groove and the application of those techniques. So without further ado, I'd like to introduce Dr. Most. Thank you for coming on board and sharing with us today.
Thank you so much. It's an honor. It's a pleasure to be here. And saying that you were my fellow 12 years ago just makes me feel old. So thanks a lot for having me. It's really great. And I think, in these times, it's good to take these opportunities to try to teach. And I really appreciate you making the effort to do it this way for everyone. So I'm going to talk a little bit, as Dr. Barrera said, about preservation rhinoplasty. So I'm going to try to go to share a screen here. And let's see. Okay, can you see this?
Sure can. Here it is.
Okay. So I'm going to talk about preservation rhinoplasty. And as we'll see in a few minutes here, it's a technique that's been around for as long as rhinoplasty has been around, so over 100 years. But I'm going to talk a little bit about the history and then about a modification that allows us to use the structural techniques that we've learned over the past 20 years, 30 years, to perform a structural preservation rhinoplasty, which is a term that we've coined and we're going to be publishing on. We actually have already published a bit about this, so I hope you find this informative. And I have no disclosures, and if you want to contact me, this is my contact information. So a lot of what I'm going to talk about here is covered in this paper, which I'm going to plug in case anyone wants it. We actually went through the effort of paying for this to be open access, so anybody around the world can download this from the Facial Plastic Surgery and Aesthetic Medicine website. So please feel free to do that. I did that on purpose so that people could learn from this if they wanted to have a hard copy of it. And I'm editing an issue of Facial Plastic Surgery Clinics covering preservation rhinoplasty, which will be coming out this year. I'm in the process of going through all the papers. We have contributors who are known as knowledge leaders in this area right now. So just look for that. So, I was trained in the Joseph technique for hump reduction. And at the time, I thought it was the only technique. And that is the classic dorsal reduction that I think most of us have learned. And that is resecting the top, creating an open roof, and performing osteotomies most of the time to close that open roof, and all the mid-vault techniques we then use to reconstruct the nasal airway or preserve it. In the late 1800s, at the same time that the Joseph technique was sort of being developed by various surgeons, even before Joseph did it, there was another method which was essentially the opposite, to cut at the bottom and push the entire framework down. And these are reviewed in that paper. I'm not going to go into too much detail here, but really in the 20th century, Maurice Cottle is the one who picked up on this and was the biggest advocate of this technique. And so you might hear about the Cottle method, but really it wasn't necessarily his method or his idea, but it was something he adopted and modified. But what I really want to talk about is for those of you who are established surgeons, or those of you who are fellows and learning, or just out in practice, we come out of fellowship limited by, I think, what we've been able to learn in that time. And what I always tell my fellows, and Dr. Barrera is a great example of this, is that I expect you to go out and learn lots of new things and add tools to your toolbox, because if the only tool you have is a hammer, everything looks like a nail. And when I think back to my training, I have added a lot into my repertoire, and I hope all of you guys do. And even if you're established in practice, you should be flexible enough to recognize new methods that might do things for your patients which improve outcomes. So preserving the nasal dorsum, as I told you, goes back to the late 19th century. And so the idea is that you cut around the base, and this is just a Gunter diagram I borrowed. You cut around the base and you push the entire thing down. And there are some variations in the way the osteotomies are done, and there's variations in the way the septum is treated. And those are where you get the different methods that you hear about. So in the caudal method, this is basically how the septum is addressed after the osteotomies around the outside are completed. Do you see my arrow?
I don't.
Okay, that's okay. Well, just pay attention to the shaded areas, and those are areas that are resected in the septum, and the dotted lines represent cuts. A goes to A prime and B goes to B prime, and the entire thing rotates and pulls the dorsum down once the osteotomies are completed. And this is a cadaveric dissection. Let me just play this video for you showing this after the sidewall is removed. So you can see the missing segment of septum underneath the digit on the left, and then how the septum rotates forward and pulls the entire thing down. Pay attention to the step off of the nasal bone underneath that finger, which is one of the issues with this. And also notice that you have to keep tension on this by suturing this caudal septum to the nasal spine, otherwise the whole thing will flex back upwards. This is the caudal method. And so if you took a cross section of a nose and looked at the septum and the sidewalls shown here in gray, and the base or the facial plane is shown in black, this is where you make this is what happens when you do a push down. A push down literally means cutting the bone and just pushing it into the face, so to speak. And so a letdown is a little different. And in a letdown, you actually resect a portion of bone, shown in the red areas there, and the entire framework just falls down into place, like so. So when we talk about letdown and push down, the difference is in the way we address the bony vault. And then the other methods all sort of vary the way we treat the septum. So there are two things to consider. Yves Saban is a friend and colleague shown up in there in the upper left-hand corner of mine, who really has been a big proponent of doing dorsal preservation rhinoplasty, and he does it endonasally. And his method, which is a modified method, is essentially to resect the septum as shown in the shaded area here, a little different than the way caudal does it. And it has the advantage, I think, of a little bit more control and less tension at the caudal septum, requiring a suture to the nasal spine. And so he's shown some very nice results over the years. And you know, his method has sort of had a resurrection in the past, I'd say 3 or 4 years, and has become popularized by a number of surgeons. And so with this, the resection and the cross section is up right underneath the dorsum, as shown there, and a push down would look something like this. And again, the letdown is a difference in the way we treat the bony vault. The septum is resected up there at the top, just under the dorsum, and the whole thing drops into position. And for those of you interested, there are a few papers that Yves Saban has published on this you can look up. Looking at these techniques, and I'm a more recent adopter of this method. I've been watching on the sidelines the last 3 or 4 or 5 years as folks started talking about this more once again. I wanted to take advantage of the methods that we use for structural rhinoplasty, which I'm a big proponent of, with an open technique, and also incorporate some of this because I thought it had some advantages for preserving the dorsum and the mid-vault area. And so with a method that I have performed and have developed, we resect the septum as shown here, preserving this caudal strut, and this is done with an external technique. We then resect a portion underneath this corresponding to how much we'd like to drop the dorsum. So this is our variable resection area. You need to split the septum in order to flex it. This is sort of like the caudal method, but you split this, otherwise that acts as a brace and prevents it from flexing downwards. You perform your osteotomy, your transverse osteotomy, as well as the lateral osteotomies. Now those can be either let down or push down. And you drop the entire thing into position. I use PDS suture as shown there in purple to keep it in place, and it heals that way. This allows us the advantage of keeping that caudal strut intact. As we'll talk about a little bit later, I like to perform tongue and groove or septal extension grafts and things like that. You can keep all of those in your armamentarium for stabilizing the tip with this method. And if you need to resect a bit of septum, you can do this as well. You can resect this section of septum shown in red, and you have this T-strut that you maintain. Obviously, if there are other issues with the septum, you may not be able to do this. For example, you might need to do a complete anterior septal reconstruction. And incidentally, I've done a few cases that way, and we're going to be publishing a paper about that in that issue of Facial Plastic Surgery Clinics. I don't recommend that if you're starting out. It's a little bit tricky. So this is a schematic of the modified subdorsal strip method, as I call it. And it shows here A going to A prime, B going to B prime, and dropping it into position. And so if you look at this figure, which is from our recent paper, you can compare all the different methods. The cross-sectional plane is shown on the left and through the nose, the level of the cross-section. And then on the right, we have the different methods. And you can see where the resections are. And I think this really helps kind of solidify and picture in your mind where we're doing our cuts and where things are being put into position. So let's talk about a case. This is a patient who came with a dorsal hump. She has a very nice tip, which makes it a really nice case. She has a little asymmetry of her dorsum. If you look closely, she's deviated to her left. And so with this technique, you can actually rock the entire vault into position if it's a mild deviation. And I'll show you in a minute what to do with more severe deviation. So we're going to do our modified subdorsal strip method in her with an external approach. And so in this case, it was also a letdown. And this is the methodology here again, shown schematically. And so here's our plane of cross section. And what we're going to do is drop the whole thing into position with a letdown like so. This is an intraoperative view of a different patient, similar idea though, showing how the caudal strut is left intact. You can, I think, identify the medial crura split there. This is an external approach. The dorsum is intact. I've made a cut in the septum, and the cut's going to go posteriorly, and then a portion of the septum is removed as shown here. And once that's done, the entire dorsum can be flexed up and down. You can see how it's dropped into position. There's a little cut that you can make in the bone up above. I recommend not resecting bone because it can actually cause that step off to be worse. You want to avoid that if possible. Once you get the level that you want, you can actually then suture it. So that's what I recommend. This is a PDS suture being placed. This is the level that I decided intraoperatively was the right level for that dorsum. This is a side view showing again how the entire thing is dropped into position. And that caudal strut is going to be trimmed after the tongue and groove and the tip is set so that you don't have bulk in that area. I like to leave that because often I'll use an alar spanning suture to secure the tip in addition to the tongue and groove if I want. I like to have that option, so I cut that as one of the very last steps in the rhinoplasty. And so this is the schematic for her. It's relatively straightforward. You can see that the letdown was performed. I use a piezo. I'm going to show a video of that in a minute. And all that was done was an alar spanning suture and a tongue and groove to stabilize the tip. It was a relatively short procedure. This is an intraop view, sutured up, what it looked like. And this is a 6-month follow-up. Now, some of these patients, most of them are less than a year because a lot of them I performed last spring and summer, and I was supposed to see them back recently, and I haven't. So this is the most lengthy follow-up I have for her. Here's a 3/4 view. Front view, you can see she's more symmetric. The dorsal aesthetic lines are great. I can tell you that that's one of the big advantages that I see with this procedure is it does a really nice job getting really natural dorsal aesthetic lines for these patients, and I'm very happy with that. And that's one of the main indications for me for doing it. And here's a base view. And you know, I'm trying more and more to show functional and aesthetic outcomes quantitatively rather than have patients and my audience just take my word for it. So in this case, these are our schnoz scores. The top 4 scores are the preoperative breathing scores, and the bottom 6 scores are the scores for aesthetics. And you can see postoperatively, she had a really great outcome. Okay. So here's another case I want to show, and this is a case with a more asymmetric dorsum, severely deviated to the left. And you know, I tell all these patients that we can't make you 100% perfectly straight, but we should be able to make things straighter. And I want to make sure they always have realistic thoughts in mind in terms of outcome, and she did. There's a ptotic tip there too that we want to address. And so this modified subdorsal strip method was used. And with an asymmetric bony vault, you can actually measure and decide how much to resect asymmetrically to drop the dorsum into the right position. So in this case, we measured, and you can perform something like this and rock the entire dorsum into the right position. I think this is really nice for crooked noses. And so here's a sped up view showing the markings for the letdown on the right side and the left side of the screen. That's how much I measured I wanted to remove. And this is the piezo being used to perform the cuts. I always use the piezo for this. I just like the control that I get with it. And so on the opposite side, you want to do your resection. And so when you're doing a letdown, it's very important that you do the medial cut, or the anterior cut, I should say, and then the posterior cut second. There's the bone that we resected on that side. Because if you do it in the opposite order, the vault is unstable, so it's harder to do it. And then you can do your transverse osteotomy with an osteotome, as shown here in a second. Let me just play this. This is showing the septal resection. And so I'm just marking it out. And you can see the caudal strut is being preserved, and then resecting a portion of that cartilage. This is it coming out, okay? And then I like to mark sometimes with a needle exactly where I want that dorsum to flex, so I can see where I need to make the upwards cut with a 15 blade, which wasn't shown. And then you can see just a little bit of cut in the bone. That time I used a through-biting forceps to do a little bit of removal, but I caution you to do that very judiciously so that you don't get too much of a step off or any. And here, osteotome is used. Sometimes you can do this with the piezo. Osteotome also has its own advantages. And then here, suturing the caudal strut to the level that I want. And then here it is afterwards. You can see it's a bit straighter, having shifted into position. So this is a diagram of what was performed there: structural preservation, rhinoplasty, asymmetric letdown with modified subdorsal strip method. I did use a septal extension graft in addition because the caudal septum was off the midline, and a tongue and groove. So again, structural techniques were used in addition. Very slight cephalic trim. I really try to minimize that, and a little bit of morselized cartilage in the right tip. And so this is, again, the concept of the modified subdorsal strip method. And here's the patient 4-month early post-op, a little bit of tip swelling still, but you can see the rotation and the dorsal reduction. 3/4 view, and then the front view, you can see that there's still a little bit of asymmetry, but this vault is much straighter than it had been here, and also the dorsal aesthetic lines look pretty good. Slight deficiency in the right super tip, but I think that's going to be okay. And base view. And pre-op and post-operative schnoz scores. I think this is the last case that we'll talk a little bit. This is a patient with a curved dorsum, overprojected tip. She also wanted her alar base to slightly reduced. She overall is pretty good on her frontal view with the dorsal aesthetic lines, a little bit of width here in the mid vault, but pretty symmetric. Very few people are 100% symmetric. And so structural preservation rhinoplasty was performed with modified subdorsal strip method. Tongue and groove was used, lateral pearl overlay to get additional rotation of 3 millimeters. And I got a little bit of a step at the radix, so I put a tiny bit of morselized, very finely morselized cartilage up there, which is your fail-safe if that should occur. And again, this is what we used. And here she is post-operatively. This is about 6 months or so. There's a very slight irregularity of the upper dorsum, but that she's very happy with it. I'm overall happy too. This is her 3/4 view showing the tip rotation. She had alar base, very slight alar base reductions as well. Frontal view, base view. And she has a little bit of stuffiness post-operatively, but I think this may be allergic in nature, seasonal. So we're following her, but she's very happy with the results, and so am I. Oh, I think this is the last case. Sorry, this is the last case. So here we have an asymmetric dorsum asymmetric tip, very ptotic. She has a low radix, which you have to be really careful with the preservation techniques because you don't want to lower it any further. So I wanted to just do a slight reduction, but mostly use structural techniques to rotate and stabilize that tip, which we're going to talk about after this. And so again, modified subdorsal strip method, structural preservation rhinoplasty. This is the septal resection that I did in order to perform some other things. So it was an asymmetric letdown, tongue and groove, very slight cephalic trim. I used mini lateral pearl strut grafts, which is another method that we've published about to help shape the tip. Very small amount of morselized cartilage in the super tip and a cap graft to give her a little bit more elevation of that tip, giving her thick skin, a little more definition. And here she is, sorry about that blurry wording there, but here she is 1 week post-op, which we don't usually take photos of, but we did this time. Just to show that, and then I'm going to show you longer term results in just a second. Here's her frontal view. She was very happy with this. Here she is about 4 months, and she's due for her nearly 1 year follow-up soon. 3/4 view showing the tip rotation. Frontal view showing straighter on the front view. Good tip definition despite being an early post-op, and I expect that to continue to get better. Better symmetry of the tip. the infratip lobule, and here's her base view. And these are her schnoz scores pre and post. So we've taken an initial look at our outcomes, and we found that, and I want to thank my colleagues, my fellow Priyesh Patel and Mo Abdul Wahab and others who've helped get this data together. But our initial data looks like this technique does work well. We get improved breathing if we need to address that, and the aesthetic scores look really good too. So this is a summary slide. Again, this image from the paper showing the different methods. I think it's really instructive to look at that and understand where the different cuts are. If you're going to think about doing this, I suggest watching a few and doing some cadaveric dissections if you haven't done it, so you can add this to your toolbox in a way that ensures that you continue to get really good results for your patients. And we didn't talk too much about indications, contraindications. I guess we can do that in a minute, but there are some. I think that with this modified subdorsal approach, you can perform a structural preservation rhinoplasty, which again is a term that we've coined and we like to use when we talk about this. The mini caudal is essentially the way you do it, because you rotate that small piece of cartilage down. It allows for harvest of cartilage for all the different techniques we use in structural rhinoplasty. And in addition to that, you can even perform anterior septal reconstruction, extracorporeal septoplasty once you get really familiar with this, in certain cases if you need to. Again, this is the contact information for any of you who want to get a hold of me, and I want to thank Dr. Barrera for letting me talk about that. I'm going to stop sharing now. There we go.
Great.
Am I back?
Great. And Sam, thank you so much for that wonderful presentation. It's very interesting as we see Saban and others really popularize something that has been done for a long time, and seeing the modifications that you've done and others have done. And a question for you, Sam, and this is an open streaming of this, and so those that are signed in can ask questions as we go through this presentation. But on the preservation, you didn't speak as much on what do you do if you have a caudal septal deviation at the same time? What are you using to fixate the caudal septum? How are you appropriating the caudal deviation with maybe a struck graft or something else?
So one of the bases for my doing this is to maintain that caudal strut because I like to use it for tongue and groove. And this is a great segue into what we're going to talk about in just a little bit. But basically, I can do all the things that I normally do in rhinoplasty prior to learning preservation with this method because of that caudal strut is maintained. You can, if it's slightly deviated, well, first of all, I like to not release it. If it gets released off the spine, I suture it back into place. We use tongue and groove to stabilize the tip onto that. If it's offline and I want to use my tongue and groove, which we'll talk about in a minute, I'll use a septal extension graft if I need to lengthen the nose. All that stuff you can do. And so to me, it allowed me to maintain my ability to use the techniques I'm familiar with and confident about while adding something to it with preserving the dorsum. And in a very few select cases, I've actually performed extracorporeal septoplasty, the modified anterior septal reconstruction that we've written and talked about for a while. With this, and that description is going to be coming out later this year. But that's one of the things that I really like about it. All the things that you do, that I'm sure you do with your caudal septum, I think you can do with this. It's just stepwise adding it to your repertoire.
Another question, Sam. In a deviated nose where you have a mid-vault collapse, and you want to put a spreader graft, or maybe a double layer spreader graft. Have you performed a letdown as well as simultaneous spreader grafting in order to kind of bring up the mid-vault?
So I have, and I didn't really show any diagrams of that. Not a double layer. I've done single spreader grafts, and that's one thing that we do with the ASR with this. But one advantage again of this method is that you can place a spreader. I have not fully released the upper lateral cartilage all the way across. I've tried to maintain it, and if I do release, it's just a little bit in the supratip area to augment that a little bit. So one, I think, advantage of this technique is it allows you to easily, because you have access to that septum, you can see her looking right underneath those upper lats. You can place spreader grafts in there if you want, and I've done it while avoiding release of the upper lat completely.
Yeah, I figure so this technique, what I'm hearing from you is that with this technique, you can pretty much do many of the structural methods that you normally do while preserving the dorsum and having sort of a surety that you're going to have nice dorsal lines. Have you found that in someone who has asymmetric dorsal lines, so for example, someone who has a high septal deviation, that there's some limitation with this technique?
I think the high septal deviations are a problem with any dorsal hum production. And we actually talk about that a little bit in this paper. That you can run into problems with either technique. If you're doing a Joseph technique and you do a hump resection and you see that the dorsal septum is, for example, deviated to one side, that nasal bone will not infracture as well on that side. And that can be, you can actually make a crooked nose look worse if you wanted that nasal bone to actually mobilize more and the opposite one to go to the other side. And we have some diagrams showing that in that paper. But the same thing can happen with dorsal preservation because you're dropping it down. But that as long as the dorsum has a good shape to it, and you're not dealing with nasal obstruction due to a high septal deviation, when you drop it down, it doesn't really matter so much what's happening underneath as long as you make sure it's midline. So you can drop the dorsum down on top of an asymmetric septum and let it overlap even to make it look straighter and suture into position that way. You just have to be careful that you are not creating a new nasal obstruction or failing to treat one. Personally, I think in a lot of cases when you have a high dorsal septal deviation, you unmask it often. The dorsum can look straight externally. And I think this is one reason why I see revisions often because patients say, my nose was straight before and now it's not. And when I go to revise them, I see that, no fault of their own, the other surgeon had opened it up and the septum was over one side and probably the nasal bones fell in asymmetrically. You can avoid that with this because the whole vault is intact. And again, as long as you're not failing to treat or worsening a nasal obstruction by not treating that high septal deviation, when you drop it down, that's all masked.
Yeah, that's great. So maybe we should go ahead and segue into tongue and groove. And I'm very interested in just to learn a little bit about how a high tongue and groove will affect tip rotation and projection versus a low set tongue and groove. So can you talk a little bit about that?
Yeah, I'm going to do a little talk here. Is that okay?
Yeah, that's perfect.
View diagrams. Let me share this.
We're going to go ahead and start taking some questions as well through this presentation. So if anyone out there has any questions for Dr. Most or myself, please go ahead and post on comments and we'll get to those questions.
Can you see this?
Here we go. Yep.
Okay, great. So let's talk about the tip tripod complex. And again, this is hopefully information that will be useful to surgeons and especially novice surgeons who are starting out. And when you think about the components of the nasal tip, this we're talking about here is going to affect rotation and projection. And we hear about the tripod complex, and I think sometimes it's hard for people to visualize what we mean. What we're talking about is essentially the paired medial crura are the medial strut of that tripod, and the lateral crura are each one is individually a leg of the tripod. And this is Jack Anderson's credited with really coming up with this metaphor, and I think it's very useful. And so we want to alter rotation and projection by altering the way these tripod legs behave and how they are related to that caudal septal construct, whether it's native septum or something else. So we can alter rotation and projection by altering the way these are connected to that. And so, for me, the tongue and groove method allows me the most precise positioning of the alar cartilages in relation to that septum or construct. So what I like to think about are there's four major outcomes to consider when you're doing the tip. You're thinking about the tip in relation to your rhinoplasty. These are projection, rotation, columellar show, and stiffness. And again, these are available in a couple of papers that we've published, myself and Dr. Spataro, so one of my former fellows. And so I'll give you those references at the end here in a minute. But I think two of the criticisms of tongue and groove are columellar show, namely retraction of the columella, and stiffness. And so I'll talk about how I'm able to mitigate that. Now, in this sort of base view of schematized lower cartilages, the red dot represents suture entry point. And I think one of the key things is that the distance from the suture entry point to the caudal edge shown in MCE and MCE prime, must be equal on both sides, and the distance of the tip defining point, which is MCTDP or prime, must be the same to create a symmetric contour. Another thing is I've found that this normal angle of divergence, which really had not been described prior to our paper, is a term that I like to use for the natural distance, which varies patient to patient, between the caudal septum and the posterior margin of the medial crus. And so this will vary. And there is a gap there, though. And at the base, towards the medial crow's foot plates, it tends to overlap in just about everybody, unless their septum's been shortened iatrogenically. So this is something to keep in mind when you're performing a tongue and groove procedure, because, as I'll show here, for any suture entry point that is constant, shown in black, and a variable shown in red, going from point A to point B, you will get decreasing columellar show as you retract that columella. Rotation will increase because you're closing that angle of divergence which is normally there, and projection and stiffness will be the same. Projection and stiffness are dependent on the distance from the suture to TDP, or the tip defining point. As you move from point A to point B for any given point on the medial crus, if you move your suture up and down the septal construct, you will increase rotation and increase projection. Rotation because you're closing that angle, and projection for obvious reasons. And stiffness and columellar show will stay the same. Going from point A to point B, so now you're varying the position on the medial crus, you're going to decrease projection and increase stiffness and rotation because the distance from the tip to where it's fastened will be decreased. There's less recoil, and the tip's going to feel stiffer. And columellar show is constant here. And by the way, these diagrams are all available out there, and there's a video on this too on the old JAMA website, which I think hopefully transferred to the new journal. And for any point A to point B movement of the suture entry point in the medial crus with a constant septal construct suture point, you're going to get decreased rotation as you close that angle, increased columellar show, and stiffness will be constant because the distance to the tip defining point is the same. So these are a lot of things, but they're kind of intuitive when you think about it, and the nuances of this are something we've published in a couple of papers, this being one of them, and I encourage you to take a look at that. To kind of understand these if I went through those very fast. So let's just talk about a case with asymmetric medial crural contour and a ptotic tip that we want to rotate upwards. So the medial crural are asymmetric. You'll see in the photographs, we want to take these caudal edges and make them more symmetric by moving it up, which is going to be shown here. And you can do that with this technique. I think that's a big advantage of it over things like columellar struts and so on, to me. And so the contour lines are set by having symmetric external edges, and that's why those two numbers that we talked about have to be the same. So this is a patient with asymmetry of his tip, deviation to the right, deviation of the midvault to the right, very ptotic. When smiling, it really drops, and you can see the medial crus on the left is hanging lower than the one on the right. And so in addition to a number of other procedures in him, tongue and groove was performed, lateral crural overlay, in addition to tongue and groove to achieve rotation. So it's not necessarily the only way you need to do it, and a few other things. And so this is the lateral crural overlay, and this is what the tongue and groove looks like. This is from about almost 10 years ago. Different patient, just showing again the concept that the distance to the caudal edge of the medial crus and the tip defining point that you're trying to create have to be the same on both sides. So you make note of that when you place it there, and then when you place it in the septum. Then I'm going to skip a little bit here to the putting it in the other side. And again, now here, this is a 5/0 proline, by the way. I like to use that for this. And so I think we're going to show here the distance. I'm taking a look at this, and sometimes I'll measure it. Usually I just do it by eye. And then when you suture it in, you can make sure that those are symmetric. And so when you're doing tongue and groove, the major variables to consider are suture position on the medial crus, and medial crural width and stiffness are, of course, going to influence where you place it, and the suture position on the septum, which is affected by caudal septal length and the angle of divergence between the septum and the medial crus. If it's something you don't want to close down and you don't want to shorten the nose, then you need to put the suture more posteriorly towards the posterior septal angle. And this is the patient postoperatively, 1 year out, showing tip rotation with those combination of lateral crural overlay. And again, the symmetry is improved on the frontal view. He does have asymmetric alar bases, but that's a congenital thing. But the medial crural contours are more symmetric. And then here's a smiling view showing stabilization. 3/4 on the other side, and base view. This is something we use routinely for our patients, even just routine hump takedown. So this is a hump takedown. This is done with the Joseph technique, by the way. I'm going to show about 7-year follow-up on this patient. So auto spreaders and standard osteotomies were performed. That's still a valid way of doing things. I'm not saying that it isn't. But tongue and groove and lateral crural steel was performed to stabilize and rotate the tip. Here he is, initially about 1 year out and 7 years out from his surgery. 3/4 view, this is 1 year and then 7 years. Showing the tip rotation and tip definition you can get with things like tongue and groove and lateral crural steel. So that was just a brief review of that. The tripod method, I think, is really important for understanding tip position as a function of medial crural and lateral crural length. Tongue and groove allows for stabilization of the medial cruce element, and with really good control long-term. Criticisms of the method include stiffness and retraction of the columella. If you look at the original descriptions by Foda and Kreidel and others, this is a little different the way we're talking about doing it here. And we're going to talk about SCGs, but it allows for creation of a midline stable base. It's really important that your caudal septal construct or septum itself is in the midline when you do this. Otherwise, you will create a crooked tip. Again, this is my contact info. I'm going to stop so we can have a discussion. I think if there are any questions, and we can talk about it, and then we can talk about the next topic after that.
Great.
There we go.
Great, super, thanks, Sam. So with the tongue and groove, one of the things that often comes to mind is many of us have used columellar strut grafts in order to provide some kind of medial crural support, also to help with medial crural asymmetry.
That's actually how I was trained, yeah.
Yeah, and it's something that is still being used today. I use it as well, but I've gone quite a bit into more tongue and groove and using septal extension grafts. Part of it because of the idea of, do we have proper tip support, and is the tip going to drop? A columellar strut graft is a floating batten graft, if you will. It's not very structural, and so even though it could provide, it could allow you to straighten out a medial crural segment, it may not be very supportive, and the tip can drop over time. Have you found that to be the case with columellar strut grafts?
First, I want to put a disclaimer in here, which goes for all the things that I'm talking about. And I think maybe unlike some people, I'm not saying that my way is the only way. I'm just sharing my experience, and I fully recognize that people have great results with lots of different methods. So that's just the truth.
Sure.
And it drives me nuts when people, try to imply that there's some other thing going on. But anyway, I trained with columellar struts. Originally, we were taught that every time you opened a nose with an external approach, it needed to have a columellar strut. Anytime you hear the words every or never, there's some never things, but you always have to do this or that. You have to sort of think about it, and I encourage everyone who's out there to always think critically about what they're doing. And really, what you need to do is make sure that you restore tip support in some way when you perform any rhinoplasty. You don't destroy tip support mechanisms, and you restore them. The columellar strut can work fine, I think, if you're using it a certain way and in certain patients. I personally wasn't happy with a few things about it. I didn't like the fact that some patients complained of clicking. I didn't think it provided as much support over the long term when I looked at my results over a few years when I was starting out. And I think most importantly, when I looked at profiles of people who had columellar struts, and I can see them, when I look at published results or whatever, it just looks like the columella and the relationship to the infratip lobule has been changed, and it just doesn't look natural to me. I think that was probably one of the major things, and maybe it was the way I was doing it, or when I looked at other people the way they were doing it. I know some people get great results and don't have that issue, but I just found that I had much more control of that, and I didn't get into so much about looking at contour with this. I did a little bit about asymmetry, but I think you have really good control of where the nasolabial angle is, where the infratip lobule junction is, in combination with other tip techniques using this. And so I just found also that my results were just better. So I think that you can get good results with a variety of methods. I think a lot of it is surgeon dependent. And for me, this just works better.
Yeah, and it brings up the point that I also want to share. I'm going to share this this paper here, so we can bring this up regarding nasal tip support. And so let's see here. So one of the things we did was we looked at a paper. I'm not sure if you can you see that?
Yes.
Quantified changes in nasal tip support.
Yeah.
So we looked at this about 5 years ago, and one of the advantages that we had at my military hospital was that we have quite a extensive advantage of using lots of different tools, and we have fresh cadaver labs, and so what we did was we took a motorized controlled test stand with a digital load cell, which can measure precisely how many force newtons can be applied to the nasal tip and give you an output. And so we looked at the compression force of several techniques, and with an open rhinoplasty. And so after elevation of the skin soft tissue envelope, we looked at the resistance to compression amongst these different techniques. And one of them was the columella strut graft. Another one was just doing lateral crural steel as an example for providing tip support, and then a septal extension graft or caudal extension graft, and trying to calculate what major and minor support mechanisms need to be, like you said, to be reestablished, but how you can further increase support. And one of the things that we found here, and I'll show you this here. Can you see that graph there?
Yes, yes.
So we're looking here at the force to compress the nasal tip in force newtons, and the pre-op force in newtons that it takes versus elevating the skin soft tissue envelope and performing a septoplasty, and dome sutures versus columella strut. And you can see here that a caudal extension graft or a septal extension graft is significantly more resistant to compressive forces. And when we look at this chart here amongst these different techniques, pretty much dome spanning sutures and septoplasty and columella strut graft, they're pretty similar as far as resistance and force newtons. But when we look at a septal extension graft or caudal extension graft, you can see the amount of compressive forces that you can apply to the nasal tip. It really withstands. And the more force you apply to the nasal tip, the more resistance there is to compressive forces. So one of the things we ascertained from this paper was that if you want to provide nasal tip support, something like a septal extension graft, it may be a good technique for that specific aim. Now, of course, you have aesthetic goals that have to be kept in mind in this. So with this research, this is one of the things that I often consider in patients, especially in my population of thick skin nose and weak cartilage patients that need further support, and as well as patients with a significantly deviated nasal tip.
That's really great. That's really great. Go ahead. Sorry.
Oh, no. So I wanted to ask you, Sam, about what your thoughts were about the septal extension graft and how you use that and with tongue and groove techniques.
Quick question. Did you, those are in cadavers?
Those are cadavers, yeah, fresh cadavers.
And did you just put the SCG in and suture it to the medial crural, or was it just putting it in and feeling how much it stabilized that?
Oh, no, that's actually suturing to the medial crural, yeah.
Okay, yeah, so great. Okay, perfect. So great segue. Let me go back to this. That's really interesting, and I'm glad you did that because it's very useful to add to the literature. Let me see here. Okay. Okay, can you see this?
Yes, I can. And just a quick comment. We're going to log into YouTube and see if we can get some of these, some of the questions that are being asked. We're having a little bit of an issue on StreamYard to display some of the questions. So I'm going to log into YouTube and see if we can pick some of those up.
Sure. So this is an example of a patient for revision rhinoplasty, and often I use septal extension grafts in revisions, but I'll use them in primaries as well. And the key concept is controlling nasal length, but again, also you can use the septal extension graft to create a midline base stable structure in order to stabilize the tip in that midline. And you know, I can't emphasize enough how important it is to determine where the true midline is, and that could be an entire talk in and of itself. That's the patient who'd had prior surgery endonasally, and so our plan is, you know, she was consented for rib cartilage. We ended up being able to use septum because it was untouched, but amongst other things like alar reconstruction and repositioning, because they were completely missing, they'd been completely resected. Septal extension graft was placed. I placed them side to side, not end to end, and a left spreader graft and camouflage grafts and other things. So the concept here, again, thinking about a tripod, is to extend the septum, and it's a key when you place this extension, to make sure that it goes on the side that'll place it in the midline. And there are lots of tricks that go into that. And then you can take the whole tripod complex and move it down. This is a quick video showing this diagrammatically, how you can resect a portion of the septum. That's, of course, the area you want to preserve, and take a septal extension graft, and then take it out and suture into position. Now, there are a lot of different ways of doing this. Some people like to do the end-to-end and suture it over the top with a template. Again, for me, I like to stabilize it side to side. This is just showing it being placed into position. This is not the same patient, and being secured to the septum. And in the interest of time, I'm going to skip that, but it's just sutured with a few 5-0 Prolene sutures. This is showing the patient on the operating table. You can see here on the right hand that the domes were present, but nothing lateral to that, so those are completely reconstructed. This is not the same patient, but just showing how I like to do lateral curl repositioning with suture, securing it with PDS into position. This is the patient a year postoperatively. And I think the things that you really look for are the improvement of the bossé, but also the lessened retraction, the reduction of nostril show, and the lengthening of the nose with a septal extension graft to a much more normal position. And so this is an up-close view showing the improvement in the tip with that. Now, the opposite can happen. This is a patient who also came to me for revision, and amongst a variety of things which are going on here, I want to focus on the ptotic tip and the excess length of the nose. And in this case, we want to take the tripod complex and move it back. In this case, tongue and groove was used, but his caudal septum remnant was very twisted. And I don't like using homologous rib that much anymore. I did at that time because he did not want me to use autologous rib. So in addition to lateral curl overlay to shorten him, I needed to stabilize the tip on a very floppy, excuse me, asymmetric caudal septum. So a septal splinting graft was created, and I'm going to skip through this just in the interest of time so we can take questions. And that was secured with very minimal extension, and then tongue and groove was used to secure it into position. And here he is over a year out, showing shortening of the nose into a much more appropriate length. Tip position is much improved, and we also did other things to his mid-vault and his dorsum, which we're not going to get into here. So, that was a really quick dive into septal extension grafts, but I want to again emphasize that if you think about the tripod concept, you want to stabilize the tip into a position that's going to be where you want it to be, and more importantly, that it'll stay there for a long time. And it's a function of the medial curl and lateral curl length that you create or adjust. Septal extension grafting allows for creation of a stable midline base if necessary. If the caudal septum in a primary rhinoplasty is offline, I will place a small extension graft, and sometimes I'll even resect a portion of a small portion of the twisted caudal septum and replace it with a little bit of a septal extension graft in the midline. Anteroceptal reconstruction can be used if the caudal septum is unusable, and lengthening or shortening can be achieved with this combination. And I'm interested to hear your thoughts about it, Jose. And again, that was just a really quick dive into it because I know we're running out of time, and I want us to be able to take questions as well, which I think hopefully you have coming in. I'm going to stop there.
Yeah, no, that was an excellent presentation, Sam. So, with septal extension grafts, I think that just some thoughts on it. I think it's a very powerful technique. There's been quite a bit of different leaders in our field that have been using it for weak cartilage patients, thick-skinned patients, otherwise patients that are termed ethnic rhinoplasty, but in essence, the phenotype is that it's a thick-skinned, weak cartilage patient.
Right.
But more so also for, like you showed in that one patient, a very structurally deficient, almost craniofacial patient with native alar retraction, and that you have to almost think about that there's something else going on with the skeleton, right, with the underlying craniofacial platform, and that's where augmenting it with something strong like a septal extension graft may be very useful. Mm-hmm. Now, when would you ever use a side-by-side suturing is one of the questions versus instead of end to end, for example.
Right. So, some of my very esteemed colleagues like Rick Davis and so on really love the end to end, and they get great results. I think that you have to do what's right to get you a stable result. Now, Dean and Rick have talked about putting it end to end and then putting little stabilizing grafts on the side and then doing a tongue and groove onto that. And that may work fine. I think that often, if you really look carefully at the caudal septum, it's got a very slight bend. And if you extend that, it's going to go in one direction or the other. And if you tension to it, it can over time tense to one side or the other. And I've revised patients that have had that done that need to be kind of placed in a midline position because over time it's done that. That can happen in any situation. I'm not saying that's the only reason, but that influenced me. And also, I like the side to side because I can secure it directly to that caudal septum with 3 Prolene sutures, and then stand at the top of the bed and look down and make sure it's. I like to line it up on the midline of the externally visible midline structure, which is the Cupid's bow, in the midline of the philtrum, even if the other things aren't quite lined up right. So, because that's what shows. And so there are a few other things you need to look at. And as a craniofacial surgeon, I know you know all that. But I think that for me, again, it works best to stabilize it that way. It does take a little bit. If the patient has a midline caudal septum, then you have an issue, right? If it is truly perfectly midline. But there are ways to get around that. You can actually take pieces of septum that, if you take the septum off the maxillary crest, it has a very slight widening at the bottom. And you put that maxillary crest side in front and the thin side secure it to the septum, and suddenly you've actually placed it, the extended portion, back in the midline. It's kind of hard to visualize just by me describing it, but that's something that we do. I'm sure one of my fellows will call me afterwards and tell me that I'm incorrect, but I don't think I've done too many end-to-end extension grafts. I've primarily done side to side.
Yeah. From a functional perspective, do you think that patients with a caudal deviation can be improved with a septal extension graft?
If the septum's very weak, you might be able to straighten it out a little bit, but I have a very low threshold for just removing it, as you probably remember. Right? If I have available cartilage, I'll just reconstruct it. And I think that a lot of my comfort with performing the tongue and groove and doing caudal extension grafts and all that kind of stuff comes from all of the extracorporeal septoplasty work that I did earlier in my career. I still do, but did a lot of it, and really became comfortable with just creating a new midline base to the tripod complex and removing it completely. And there have been times when it's been a purely aesthetic issue where I just wasn't happy with the caudal septum, and I just resected it and performed an anterior septal reconstruction just to get things in the midline. Yeah, no, for sure. And we have about 2 minutes left, but another question is lateral crural tensioning. So this is now a very popular technique. I've been using it myself just to provide some nice narrowing of the nasal tip, preserving some domal highlights and providing good structural support. I mean, is that something you've been using, Sam? I think to a certain extent that's something we've been doing, kind of all along. Some people have taken it to an extreme, but I think that you can. Again, the key is to create a tripod contour that is aesthetically good and appropriate for that skin thickness. And so you can tension by, with your whole tripod, elevating the medial crura and then doing your dome sutures and alar spanning suture to get it tensed. And I think it's a nice idea. I don't think it will treat everybody. I think that some people advocate it as being a technique that can be used for every lateral cruce, and I just don't think that's the case. I'll often do mini lateral crural strut grafts to straighten out a lateral cruce that's a little bit too curved with a little bit of tensioning and not relying only on that. Yeah, no, for sure. Well, Sam, we have about a minute left. It's been a pleasure to have you on today's chat forum. Feelings mutual. Thank you so much. It's great. It's great to talk with you this way too. That's right. No, Sam, you've been a mentor to me and been my fellowship director, and I really thank you for all the teaching and continued mentoring that you do. Thank you, and I'm super proud of everything you've done. You're, I think, my first fellow to become a fellowship director himself, and it's great to see you out there, and thank you so much for allowing me to share with you. Thanks, Sam. And we look forward to continuing to do some of these live chats in the future. I think that we need to continue educating folks and also having an open discussion like this, a collegial discussion that we could discuss some really good research. And thank you for leading the way with the journal as well. Thank you. And thanks for all your contributions, and hope that folks found this useful. Great. Thanks. We'll see you next time. Take care. Bye-bye. Bye.